To see, in ulnar nerve, as we discussed in case palsy, there will be claw hand deformity. Why? Because lumbrical interossei are paralyzed. Most of the lumbrical interossei are supplied by ulnar nerve, and if they are paralyzed, there will be forearm muscles becoming more powerful, anterior forearm causing IP flexion and posterior forearm causing MCP extension, claw hand deformity. Plus, you will see that there will be not only clawing of the finger, but some sensory loss, 1.5 finger anterior, 1.5 finger posterior. That is ulnar nerve injury. So, can we discuss claw hand deformity in more detail? Yeah, let's do that. This Froment test will be positive. What is Froment test? Can we explain it? Yeah, you give a card to the patient and ask the patient to hold the card, and he'll hold the card with the help of ADD adductor pollicis, and you try to pull the card. You feel some resistance, and if you can't feel the resistance, the card is slipping from the fingers. That means the ADD adductor pollicis is not working, and it is some ulnar nerve injury. I'll tell this again in another diagram. But Froment test will be positive. Froment test is to check the ADD adductor pollicis muscle. Okay, so what about the claw hand first? First, you have to discuss the claw hand deformity. This is ulnar claw hand. So, basically, the ulnar FDP is compromised, ulnar side FDP, or ulnar lumbrical interossei compromised. Now, if you say these two fingers are more apparently involved, yes. See, there is IP flexion. Can you tell me why there is IP flexion? Because anterior forearm muscle FDP has become more powerful. Interphalangeal flexion due to unopposed FDP, anterior forearm muscle. Lumbrical interossei not working. You cannot do interphalangeal extension. So if you cannot do interphalangeal extension, they will remain in flexion. And why there is MCP extension? See, there is MCP extension because hyperextension at MCP because unopposed posterior forearm muscle, which is extensor digitorum. So extensor digitorum has become more powerful, causing MCP extension here. Yes, because normally lumbrical interossei balance it, and if lumbrical interossei not working, then it is more powerful. Okay, what about the ulnar paradox? Ulnar paradox is something which is unexpected. Unexpected means like what? Like sun rises in the east, and one day sun rises in the west. So that is a paradox. You did not expect the sun to rise in west. So in regard to ulnar nerve, then understand, if a nerve is injured at high level, then normally we will expect more problems. Yeah, that is obvious. And if a nerve is injured at a low level, then less problem. Yes, that is understood. That is normal. But for ulnar nerve, what happens is, if ulnar nerve is damaged at high level, you will see there is less of problems. It is quite unexpected. And if ulnar nerve is damaged at low level, then there is more of problem. What is happening? What is this? Why there is more of problem? Explain. Why this paradox? Let us see. This is ulnar nerve. You remember ulnar nerve supply the FDP muscle, medial half? Yeah, medial half FDP. Now what? Then it is supplying lumbrical interossei later. Yeah, it is supplying lumbrical interossei later. I understand. See, the thing is, if I have the ulnar nerve injury at the wrist, more clawing, more problem. You want to say lower level lesion is giving more problem? Yes. Paradox? Yes. Why? Because if ulnar nerve is damaged at a lower level, lumbrical interossei gone? Yes. So, why there was finger flexion? Because the FDP working? Yeah, that is why. So, there is claw hand because IP flexion done by unopposed FDP. It is working. So, FDP is still working. Yes, that is why. Understand? When ulnar nerve is injured at a lower level, lumbrical interossei paralyzed and they are not balancing FDP, FDP is becoming more powerful and cause the IP flexion. So, This IP flexion is because of the unopposed FDP. Yes, that is why you have claw hand deformity, no? Now, understand, what will happen if the ulnar nerve is damaged here? Then FDP is also gone. And who will do this? It will be less clawing. Understood? See, if ulnar nerve is damaged at a high level at the elbow, less clawing. Why less clawing? Because who was doing the clawing? FDP. If the nerve injury is here, FDP is also gone along with the lumbricals, of course. See, if ulnar nerve is injured here, then not only FDP is gone, but the lumbricals are also gone, interosseous are also gone. So, but since the FDP is also paralyzed, the FDP was the one which was clawing, so less clawing. You are telling that FDP is also paralyzed? Yes. That is why there is less of clawing? Yes, that is the point. You are telling ulnar paradox in one sentence now. That is, high ulnar nerve injury, less clawing is called ulnar paradox. High ulnar nerve injury and less clawing is called as ulnar paradox. You can also understand when you compare the two, you can tell ulnar paradox in other way also. See, simply put, when there is reinnervation happening for ulnar nerve, as ulnar nerve is innervating, the FDP is getting the power, there will be clawing coming back. Clawing will come back. This is such a paradox. Normally what we expect, when the nerve is healing, the problem should solve. When a nerve heals, the problem should solve. But what is happening here? When the ulnar nerve was healing, innervating, FDP was becoming powerful and more clawing was there. So with the nerve healing, more of problems is a paradox. That way also. So simply put, you are telling reinnervation of the ulnar nerve at a high lesion deformity will get worse. Yeah, because FDP is reinnervated, will keep pulling the finger for more clawing. That is also a way of telling paradox. But simply telling high ulnar nerve injury and less clawing is ulnar paradox. As a nerve is innervating, more clawing is also a paradox. Okay, what did you tell about Froment test? Why we did Froment test? You did Froment test to check a muscle. You know that. Yeah, A double director pulses. But how do I do and how do I know that it is positive? See, you have to give a paper to the patient, card to the patient, and ask the patient to pull the paper. You mean to say you are holding the paper and patient is pulling the paper? Yes. You are pulling the paper and patient is holding the paper. Okay, then you will notice one thing, that normal adductor pollicis will hold the paper or card. So it is holding. A double D adductor pollicis will help the patient to hold the card. But can you see the other side? The thumb is flexing. Flexor pollicis longus is working to hold the paper. Oh, you are telling that here the thumb has folded? Yes, you see, to hold the paper. Why it is folded? Because patient is using flexor pollicis longus to hold the paper, median nerve. But why the patient is using median nerve? Because ulnar nerve is injured. No adductor pollicis. Oh, you are telling on this side there is ulnar nerve injury, so adductor pollicis is not working to hold the paper? No. So median nerve working and flexor pollicis longus is working to hold the paper. So that is why the thumb is folding. Yes, when the thumb is folding, it is Froment test positive. Means adductor pollicis is not working. Means Froment test positive. Median nerve is working. Ulnar nerve is lesioned. So Froment test is done to check the ulnar nerve injury. Yes, it is check the movement of adductor pollicis. Keep that as the answer. Okay, what about the radial nerve? Now we have to discuss radial nerve injuries. Yes, you have to discuss radial nerve course and then the injuries. As you see, radial nerve has all the 5 root values like the median nerve, and it is nerve of the posterior compartment supplying posterior arm, forearm, and nerve of extension, doing extension at the elbow, at the wrist, at the MCP and the IP as well. And it is supplying supinator muscle, so helping in supination as well. Now, your job is to discuss some details. You remember, it was the posterior cord of the brachial plexus continuing as the radial nerve. Radial nerve is the nerve of the posterior compartment. Let us look at the supply it is doing. As you'll find that this is the posterior cord of the brachial plexus giving you the radial nerve, which is going behind the bone humerus in the radial groove and coming in front of the lateral epicondyle, and there it will be dividing into 2 branches. One of them is cutaneous branch, supplying the dorsum of the hand, 3.5 finger, and the other will be a motor nerve, supplying muscles of the posterior forearm, which are so many extensors. You can magnify the diagram.